Folks, I'll make a quick announcement before we begin. We are right at a quorum, and one of our members may have to leave to present a bill in a few moments. So we're going to wait for at least one more member to come, maybe two more members to come in, I think, as we speak. Very good. Just 1 second. Welcome, ladies and gentlemen. We will call to order our House Insurance Subcommittee Tuesday, March 16th, 2021. Shelley, will you please call the roll?
Representative Subcommittee. Hicks. Here. Kumar.
Here.
Lafferty. Mitchell. Rudder. Here. Smith. Here. Terry. Thompson.
Here.
Chairman Hawk.
Yes, I'm here.
You have a quorum.
All right, the chairman detects a quorum. We will begin. We have a calendar today. We have 7 pieces of legislation before us, and we have several individuals who want to speak today. So we will go through this in an orderly fashion. Just a heads up for anyone wanting to come speak. We have the chairs here in front of us, as well as we have the podium in front of us. Anyone outside the legislature is welcome to go either place. Of course, our legislature will present at the podium, but if you are asked to speak on a particular piece of legislation, we would like to keep our initial comments reserved to roughly 3 minutes. Beyond 3 minutes, you'll be able to engage. Our members will be able to ask questions of you. If there are any pertinent questions to follow up testimony that you may have. Today's calendar is an emotional calendar. I'll be very frank. Lots of folks have spoken to us on the calendar before us today, and it's critically important to the health and welfare of our state and our citizens of Tennessee. So with that being said, I look forward to taking up the calendar. As I look to my colleagues to my right and my left, are there any personal orders that anyone has at the moment? Seeing none, we'll begin our calendar with item number 1. We have item number 1, House Bill 1195 by Representative Garrett. We have a motion and a second. I think, Representative Garrett, if you'd like to make some comments, please.
Thank you, Mr. Chairman. I'm working with stakeholders on both sides of this legislation, and if it's okay with this committee, I'd like to roll that a week to get this in the best posture possible for both the patient, providers, et cetera. So then I'll be prepared to present that as we continue to make this a proper and good bill.
Thank you very much. And the representative has approached me earlier and has asked ask for what you've just seen, ask for continuing work on this legislation and for a roll, and it's certainly granted. So without objection, House Bill 1195 will be rolled 1 week.
Thank you, Mr. Chairman, Committee. I appreciate it.
Thank you. Item number 2 on our calendar, House Bill 1348 by Chair Lady Helton. We have a motion and a second on your legislation. Chair Lady Helton, you are recognized.
Thank you, Mr. Chairman and members. This bill was brought to me by SIMPA Community Cares of Ryan White Clinic in Hamilton County. It received a positive recommendation from Pensions and Insurance. It passed last session in both the sub and the full committees. This legislation simply states that a PBM cannot reimburse a 340B entity at a lower rate for a drug that it reimburses a non-340B entity at the retail level. The 340B drug discount program is a U.S. federal government program created in 1992 that requires drug manufacturers to provide outpatient drugs to eligible healthcare organizations and covered entities at significantly reduced prices. The law requires the savings be used on patient care. PBMs are trying to reduce or eliminate the savings. For more than 25 years, the 340B drug discount pricing program has provided financial help to eligible safety net hospitals and clinics serving Tennessee's most vulnerable patients, the uninsured and underinsured, such as children with cancer. The original intent behind the 340B program centers on enabling covered entities to stretch federal resources farther without costing taxpayers anything. And with that, I will accept any questions, but I do have a speaker that would like to speak today.
Thank you, Chair Lady Helton. And on our list, we do have Shannon Stevenson, who is the CEO with SIMPA Community Care. If Shannon is in the room, certainly welcome.
Thank you.
Welcome any communication. All right, at this moment, ladies and gentlemen, without objection, we will go out of session. And if you could check your microphone, make sure there's a light that signifies you're on.
There is now, Chairman. Thank you.
Thank you. And for the record, if you could introduce yourself, your capacity, and who you're with.
Yes, my name is Shannon Stevenson. I'm the CEO at SIMPA Community Care based in Chattanooga, Tennessee. As Representative Helton shared, we are an FQHC lookalike, a Ryan White Clinic. We also have a location in Johnson City, Tennessee, and we serve all over East Tennessee. We've been on the forefront of the COVID pandemic as an infectious disease specialty clinic, so providing our mobile clinic in communities that are most vulnerable with testing and even as latest of last weekend vaccinations. So basically what Representative Helton covered is that the 340B program was established in the late 90s, and it was created to help give a discount to safety net providers. And what PBMs are looking to do is to usurp that savings into their pockets. So if we don't get the discount, then that means that for-profit entities can capture some of those savings, and that's not what Congress intended. And absent state legislation to help protect us, they can continue to engage different contracts and other methods to usurp those dollars.
Thank you very much. Any questions by any of our committee members? Chair Lady Smith, you're recognized.
Thank you, Mr. Chairman. I do want to take an opportunity to recognize the director, Ms. Stevenson, because indeed it is an underestimated statement for them to say that they've been on the front lines of the COVID response in Hamilton County. So I want to recognize you for that. If you wouldn't mind, I know that when we talk about Ryan White clinics, many people here know that, but I want people to understand back home. And if you wouldn't offer testimony, the typical patient that comes to you are dealing with, they're HIV positive, they have immunosuppression, and any other host of disease that may be leading into a very chronic, debilitating state. And these people are most likely, and if you wouldn't speak to this, uninsurable. They're trying to work. But the reason this is important is what we're trying to prevent and stop is insurance companies from profit sharing, essentially, off of this particular grant. But if you wouldn't mind speaking to the typical patients that you all treat. Thank you, Mr. Chairman.
Ms. Stevenson, you're recognized.
Thank you, Representative Smith. So yes, 90% of our patients are under 100% of the federal poverty level. So we do serve the most vulnerable indeed. And thankfully, we offer things like insurance assistance, which help keep a lot of our patients off of TennCare. And we're able to offer the full gamut of services because a lot of times when a patient comes into our clinic, they're not virally suppressed, meaning that they can transmit the virus to others, which could cost upwards of $800,000 over the lifetime treatment of HIV. So our goal has been, and thankfully to the 340B program, our viral load suppression in 5 years' time has gone from 73% to 93%, meaning that 93% of our patients no longer transmit the virus to others. So we offer social services, behavioral health, substance abuse if they need it, and always the primary care and clinical care for infectious disease.
Thank you. Any further questions or comments? Thank you, Ms. Stevenson, very much. Appreciate you making the journey here.
Chairman.
Without objection, we will go back into session. We have a motion and a second on Representative Helton's bill. Any questions or comments from committee members? Representative Sapicki, you're recognized. Question is called. Any objection to the question? Seeing none, all those in favor of House Bill 1348 going to full insurance committee, please signify by saying aye. Aye. Any of those opposed, please say no. The ayes have it. The bill moves forward.
Thank you, Mr. Chairman and committee.
Thank you, Chair Lady Helton. We are now on item number 3 on our calendar. Item number 3 is House Bill 419 by Chairman Sapicki. We have a motion. We have a second. Chairman Sapicki, you are recognized on the legislation, sir.
Thank you, Mr. Chairman. Thank you, committee. House Bill 419 is a bill I've been working on with the Speaker for 2 years now, trying to get chiropractic care covered under TennCare over the age of 18. This bill adds chiropractic services performed by a person authorized to engage in the practice of chiropractic to the list of healthcare services that may be included as covered TennCare medical assistance. This bill requires that the medical assistance provided by TennCare include payment for chiropractic services for recipients who are 18 years of age or older. Currently, chiropractic services are covered for children up to age 18, but then are no longer covered for 18 years of age or older. I see this bill as helping with the substance abuse problem that faces so many Tennesseans. Instead of going to a physician and getting pain meds or requiring someone to have surgery, this gives the patient another option that hopefully can address their pain needs without opioids or surgery. Committee, I stand before you as someone who does use chiropractic care. I've used it my entire athletic career, and I'm telling you right now, I would not be standing here in front of you without chiropractic care. I think this is a good bill. I think if we can find the funding for this, it'd be something to be able to add to help the people of Tennessee have better health care in the future who run TennCare. I would try to answer any questions, Mr. Chairman.
Thank you, Chairman Sapicki. Any questions or comments from any committee members? Dr. Kumar first, and then Representative Rudder, Chair Lady Rudder after that. Representative Kumar, you're recognized.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Speaking. Surprised that chiropractic care is covered under TennCare up to age 18. I would think the needs would be very small under age 18. And do you know why, what the justification for that is?
To answer that question, I don't know. 2 years ago, I asked that question of TennCare, and I couldn't figure out, I asked them, is there any physiological difference that happens after age 18 in the human body that chiropractic care wouldn't work? And the answer was no. So I'm perplexed as this. If we're trying to provide the best care we can for our recipients of TennCare, this could hopefully maybe give another option instead of getting on opioids or going through expensive or very costly back surgery.
Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Kumar. Chairman Rudder, you're recognized.
I don't have a question. I just have a comment. And I share your passion for chiropractics. I have a niece that's a chiropractor. My whole family is big proponents of chiropractic. And thank you for bringing this bill. I really agree with you and think that it will make a big difference in people's lives and keep them off, like you said, drugs.
Thank you.
Thank you very much. We have a couple of folks who have indicated they might want to speak on the legislation. Is anyone from Tennessee Medical Association in the audience? speak now, forever hold your peace. Anyone from Tennessee Medical Association? We do have folks from TennCare would like to make a comment or two, if it's all right. Ashley, is that you or someone else in the? Okay. Well, without objection, we will go into recess. And if you could, Ms. Reed, introduce yourself. You kind of know the protocol. Introduce yourself and tell us who you are and who you're with.
Thank you, Mr. Chairman and Committee. Ashley Reed with the Division of TennCare. So this bill does add Chiro to the list of covered services for individuals over the age of 21. TennCare already covers chiropractic services for individuals under the age of 21 due to federal EPSDT laws. There are really two components with this bill that TennCare has a concern with. One is the inability for us to be able to prior authorize these services, and second would be the inability for us to perform, or for MCOs to perform, alternative services such as physical therapy, occupational therapy, other steroidal drugs. We do think that this would have a fiscal impact that's likely more significant than what's listed in the official fiscal note. And also, the inability to prior authorize or offer alternative services goes against the medical necessity criteria that we have laid out in statute.
Thank you. Any questions or comments of Ashley, Ms. Reed with TennCare? Chairlady Smith, you're recognized.
Thank you, Mr. Chairman. Does TennCare currently cover acupuncture?
Yes.
And does it already cover physical therapy?
Correct.
And you said it covers chiropractic care up to 21. Why is that a distinction of coverage until you're, of age, and then not coverage? What was the rationale there?
Yes, federal EPSDT laws require us to cover chiropractic services for individuals under the age of 21.
And Mr. Chairman, if I could follow up with that, what is the EPT?
Early periodic screening, diagnosis, and treatment guidelines.
Could I make the assumption, too, that it's just to avoid using narcotic medications with that population as well, that you're trying to use other modalities rather than pharmacology in that patient population?
Correct. There is a vast array of services that we would use that does not include opioids, which would include steroids, physical therapy, occupational therapy, maybe in-home exercise programs. And this bill would prevent us from being able to use any of those services first.
And one last follow-up question, Mr. Chairman, if I may indulge. Is it wrong to assume, though, and I do know that we talked about the fiscal note, if someone's seeking care for pain, there's going to be a fiscal note somewhere. You're going to be paying, whether it's to see an orthopedic surgeon, you're going to be paying whether you're seeing the chronic, pain management. Would this just not be a fluid part of their coverage? Wouldn't that just be the case of their care being given by another entity? Thank you, Mr. Chairman.
It would, and I may ask Dr. Vaughn Prejean to come up to speak to that more. But I think, as is with chiropractic services too, there tends to be, where it's not just one visit. There are multiple visits that they may have over the course of, a long period. Whereas with maybe some of these other services, they could go, and even if it elevates to a back surgery or a spinal surgery, that would alleviate the problem, where then no additional care would be needed.
Thank you. And Dr. Fragon, your name is on the list to be called for potential testimony today. Dr. Fragon, I will allow you to introduce yourself and tell us who you are and who you're with, and begin your testimony.
Thank you. I appreciate the opportunity to be here today.
Yes, sir. Chairman Sapicki.
Is the doctor speaking on to the bill that chiropractic care does not work over the age of 21? Because that would be a relevant testimony.
Is that in your microphone, Chairman Sapicki? If you could.
Sorry about that.
And we'll get some clarity on this, on the conversation.
So the question is, the bill adds chiropractic care. Is he speaking to the point that chiropractic care doesn't work over the age of 21, and that's why we shouldn't do it? Because if it's a financial issue why we shouldn't do it, this body determines what's financially acceptable that we're going to pay for. So I'm curious to see if the doctor's testifying that chiropractic care does not work.
Okay. And Dr. Fragon, with that preface to the comments that you may make, certainly let you go forward and, as I mentioned earlier, allow you to introduce yourself and who you are and who you're with.
Certainly. Well, I appreciate the opportunity to be here today. I'm Vaughn Ferjean. I'm a physician. I work with TennCare. And I think I can clarify that question. I appreciate that, and I'll clarify also what Ashley said. So I think the question that was raised is, why do we cover chiropractic care up to the age of 21 and not over 21? And the federal law states under a section of federal law called EPSDT, which is Early Periodic Screening, Diagnosis, and Treatment, that any treatment under the age of 21, any medical treatment that can be covered has to be covered. And the rationale there is for children, anything that can be covered has to be covered. That same EPSDT standard doesn't apply over age 21. And so when we negotiated our state plan amendment with the federal government, dating back to the beginning of TennCare in 1994, and even before then, dating back to the beginning of the Tennessee Medicaid program back in the 1960s, that adult chiropractic services were not included in our state plan amendment. So they're not covered because they're not part of our agreement with the federal government. So it's not to say that adult chiropractic treatment is not value or beneficial in some circumstances, and even in some circumstances may be medically necessary. The reason that we don't cover it is it's not part of our state plan amendment. It's not part of our agreement with the federal government where we can pay for it. So any movement to cover it for adults, for anyone over age 21, we would have to go back to the federal government and essentially negotiate that state plan amendment to get coverage for adults over 21.
Thank you. Questions or comments? Chairman Subcommittee, you're recognized.
Thank you. So on that train of thought you have right there, we do have the power to go back and ask the federal government to add chiropractic care. We have the TennCare block grant, but we know our opponents on the other side of the aisle have asked the Biden administration to revoke our TennCare block grant, which means we'd have to go and renegotiate a contract coming up. So we could, if the General Assembly says, yes, we want to add chiropractic care and yes, we want to fund it, when you go to renegotiate or ask for an amendment, you would just have to ask for an amendment on our policy, correct?
That is correct.
Thank you.
Thank you. Chairlady Smith, and then we'll go to Chairman Terry after that. Chairlady Smith.
Thank you, Chairman Hawk. Just a question: if the sponsor might be willing to add a friendly amendment, what if this was a choice after prior authorization? Because I do know that you all have the ability to make a determination if after utilization review or some time of a prior authorization that might be appropriate. I mean, is that something that would require going back to CMS for a waiver, or is that still within your purview that you could do if it were, included among options after prior authorization? Thank you, Mr. Chairman.
Yeah, so there's essentially two things with the bill that we have concerns about. One is the fiscal impact associated with adding additional chiropractic services, and the second part is the language that says that we cannot require alternative services be used before providing payment for chiropractic services, which sketch our ability to prior authorize those services. So that would mean essentially that we were treating chiropractic services different than any other type of treatment. So for any other type of medication or surgery or physical therapy, anything, there's an element of a prior authorization process that's in place based on our definition of medical necessity. So I don't think it would be a question of dealing with the federal government. We still have to negotiate that state plan amendment, but it would, if that requirement for alternative services not being used was removed, there would still be the fiscal impact associated with it.
Chairman Terry, you're recognized.
Thank you, Chairman. I think some of my questions got answered, but I just, for the record, I want to clarify TennCare 3.0 is a shared savings program, and I'm not going to refer to it as a block grant. So, thank you. One of the points was brought out was extra cost other than what is in the fiscal note. So I think you were alluding to that of other potential treatments that would not be able, that aren't treated this same way. So could you just elaborate a little bit more on the extra costs?
So I think one of the issues that was raised earlier, would chiropractic treatment potentially save money and would it lessen some services? And we looked at that. We looked at when we looked at other states, and our conclusion from that is that adding an additional service would lead to increased cost. There may be some savings that are generated from the chiropractic treatment, as you suggested, from fewer opioids or fewer surgeries being used, but all across the board, and that's where we looked at some of the behaviors in other states, and that's what we provided to fiscal review, that there would be a net increase in costs.
All right. To follow up on that, so are other states covering chiropractic care over the age of 21?
Yeah, we looked at other states, and roughly half for adults. Every state covers it for children under 21 because of the EPSDT mandate. But we looked at other states, and roughly half cover it for adults and half do not.
Okay, and I think we've got one more follow-up, and that kind of goes to Representative issue about prior authorization. As it's written, there's not requirement for prior authorization. There's no alternative treatments. Is there any stop per year, like 20 visits or anything that restricts that?
Yeah, in the bill as written, there's no limits placed on the treatment.
All right, thank you.
Thank you, and I'll read from the other fiscal impact that we have, just to clarify and maybe add to the conversation. Other fiscal impact, there could be savings if chiropractic care is used in lieu of other procedures. Due to a number of unknown factors, the timing and amount of any savings are not quantifiable with reasonable certainty. There is a note as well that a surgical spine procedure and back surgeries is estimated to be $60,271. So that is a potential there. So, any more questions or comments? Chairman Subcommittee, you're recognized.
I'm doing math real quick. It won't take me as long.
He's got his calculator out.
So, can anybody in the state of Tennessee get on TennCare right now?
No,
There are restrictions to who can be on TennCare, is that correct?
that's correct.
And TennCare has funds that are available for a limited supply of people. That's why we have a waiting list to get on TennCare, is that correct?
There's not a waiting list per se to get on to TennCare, so that gets to do with how the federal funding and the state funding. But in terms of eligibility, currently there's not a waiting list to get onto the program itself.
So everybody that qualifies for TennCare in the state of Tennessee is on TennCare?
That is correct.
That is correct. So we have a fixed pool. And if we have out of that pool right now, we have back surgery, we have opioids, we have other things that they can possibly do. If we add one more in there, it's just another tool in the tool belt for TennCare to provide outstanding insurance. The thing that's the most troubling here is I keep hearing money. We're quantifying health care with money instead of doing what's right for our people on TennCare. And if we can provide average back surgery $60,000, and from the private sector, what I pay for a visit for TennCare or for chiropractic care is roughly $100. That means for that $60,000, you could treat somebody 600 times with chiropractic care. 600 times. And if we did that and still stayed away from back surgery or stayed away from opioids, the benefits of that outweigh the cost of that $60,000. So we don't ruin people's lives with opioid addiction, which we have a rampant problem in Tennessee with. I would argue that the fiscal note is wrong because it's the same people who are taking advantage of this are either going to choose back surgery, they're going to choose opioids, or they're going to choose chiropractic care. Personally, I would hope they would choose chiropractic care or maybe physical therapy before they would under the surgeon's knife or start hitting us up for drugs. I think the benefit of adding chiropractic care over the age of 21 will make TennCare and make our health care a better service for people in Tennessee. If there's something I'm missing, I'll be happy to listen. Thank you.
Okay. Any further questions or comments while we're in recess? Thank you all very much, Dr. Fagon. Thank you, Ms. Reed. We will go back into session. And Chair Lady Smith, you're recognized.
Thank you, Mr. Chairman, and I would ask my colleague, the sponsor, I'm for your bill, but I do understand the fiscal impact, and I certainly don't want to do anything to jeopardize our shared savings to the degree, but would you be willing to accept a friendly amendment that we could work on over the next day or so that would maybe cap the number of visits to potentially 2 or 3 a month, and number 2, put this in a position that it would be under a prior authorization type format so that it would leave discretion to the department, hoping that it fits into an episode of care that comes before surgery and/or opioids. Thank you, Mr. Chairman.
Thank you. Chairman Sapicki, you're recognized.
So I do understand your amendment, and I understand it's a friendly amendment. I would consider it a friendly amendment. However, Chair Lady, we've gone through this before last year with TennCare. And every time we came up with a solution, they came up with another problem, okay? And I really don't want to get into this dance with them again. I believe the General Assembly is the one that has to make the call here. Do we want to make our health care better? If you want me to roll this for a week and work on that amendment, as long as TennCare will tell me right now that that's a friendly amendment and they'll consider it a friendly amendment and get neutral on the bill, then I would consider adding that to it.
Chair Lady Smith, you're recognized. Then Chairman Terry after that.
Thank you, Mr. Chairman. And here's what I would say. I'm not in the driver's seat. The chairman of this committee is that. Here's what I would tell you. I'm going to vote for your amendment. I'm going to vote for your bill if they will not commit to that. But I will be glad to work with you and add that amendment and vote for your bill then. Because I do think that this is something, we're dealing with a crisis that's causing premature death and changing our longevity of life because of opioids and the cost of surgery. And I know the fiscal note is going to be fluid because you're in the continuum of care. So what I would commit to you is I would prefer to work with you on an amendment, but I don't have the I'm not queen for the day, and so I can't make TennCare make a promise like that. So thank you, Mr. Chairman.
Mr. Chairman.
Chairman Sapicki.
I would be happy to work with Chair Lady Smith on this, to work forward to make this a better bill. But in my opinion, once we get that language, we would have to have the commitment from TennCare that now they're neutral on the bill, and therefore we can move this forward, and then we have to start looking for money for this. If we get to a point that the amendment is made and TennCare still doesn't sign off on it, then I would bring this bill back next week in its current form and run the bill, if that's okay with the chairman.
Chairman Terry, you're recognized.
Thank you, Chairman. I was just going to echo some of the comments of Representative Smith on. I think that if we're able to work on guardrails on this, I think it may, on the front end, help the fiscal note, and I think maybe on the back end it might help us with our shared savings. But we have to have the right guardrails, and I think that that's something that we can work on outside this. So, thank you.
Mr. Chair.
Chairman Sapicki.
At this time, I'd like to go ahead and roll the bill till next week's calendar, and I'll work with everybody involved to make sure it's in the best position possible.
Okay. Thank you very much. We'll go to Chairman Kumar.
Well, thank you. I think the matter is moving in the right direction, and I'm pleased with that. I just wanted to make an observation that chiropractic care, especially in certain age groups much beyond 21, is a recognized specialty and a field that has real benefits to it, and I'm surprised that it is not. We cover a lot of other things under TennCare, and certainly this would improve lives, and I think it needs to be done, and I'm pleased that our committee and the sponsor are working towards a good solution. Thank you, Mr. Chair.
Thank you, Dr. Kumar. What the chair is hearing is that there is a request to roll this piece of legislation as we work toward an amendment. The request will be that we continue work with our with TennCare to show them the work that we have in hand and move forward with a product in committee next week. And we'll continue to have those conversations. As Chair Lady Smith eloquently said, she could not be queen for the day, nor will I be allowed to be king for the day to see what that response will be. But I think that anyone viewing this sees the good faith in which we are having this conversation. Chairman Sapicki.
Thank you.
I welcome your continued hard work on this, and thank you for your advocacy. Without objection, House Bill 419 will be rolled 1 week. Thank you all very much for your work on that. We are now on item number 4 on our calendar, and then I have been alerted by the sponsor, asked to roll this bill to the heel of today's calendar. Is that accurate?
Thank you, Mr. Chairman. Yes, just for the purpose of getting to some of these other bills and to partner the last bill with the first. They tend to go better together, the network adequacy as well as the surprise billing. They tend to feed off of each other. So if it's okay with the committee and the chairman, I'd like to proceed now to House Bill 145, which is number 5 on the calendar.
Okay. Seeing no objection from the committee as we look at item number 4, House Bill 2. Seeing no objection, that bill will be rolled to the heel of today's calendar. We are now on item number 5 on our calendar, which is House Bill 145 by Chairlady Smith. Chairlady Smith, you're recognized.
Chairman, I do have an amendment that's on this bill, 3897.
All right. Do we have a motion and a second on House Bill 145?
Motion.
We have a motion. We have a second. We are now looking at an amendment language to House Bill 145, which in my view looks to be the amendment that will make this bill.
That's correct, Chairman.
Before you, ladies and gentlemen, we have amendment tracking code 3897. Is that accurate, Chairlady Smith?
That is, Chairman.
Okay. Ladies and gentlemen, you have before you amendment 3897 to House Bill 145. I will entertain a motion and a second if it's there. We have a motion and a second on amendment drafting code 3897. All those in favor of placing this amendment on the bill, please signify by saying aye.
Aye.
Any opposed, say no. The ayes have it. Chairlady Smith, we are on House Bill 145 for your explanation as it has been amended.
Thank you, Mr. Chairman and committee. In Tennessee, we have pharmacy benefit managers. We heard a little bit of discussion about this earlier in the form of the 340B legislation. This particular bill enables and instructs our Department of Commerce and Insurance to create a more robust licensure process that adds to the current licensure. Today, the pharmacy benefit managers are licensed on a biennial basis every 2 years. Once they're licensed at $100, their renewal fee is $50 every other year, and there are very few criteria. This particular bill is written 145 and as amended will increase that licensure to $1,000 with a renewal every 2 years to $500. It will also instruct the pharmacy benefit managers to act in the best interest of the patient that are insured rather than the insurance entity or the pharmacy or the pharmacist or the insurance plan operating as a third-party administrator. And further, it will set up a complaint process very similar to what this body has heard before, a wonderful process that I know one of the investigators, Vicki Trice, is over. I've worked with her directly. She's fantastic at the department, and I think that would do a fantastic job if there would be a parallel construct for the purpose of if a patient feels that they have a covered benefit, they have not received that through their pharmacy benefit managers, there is a complaint process. So this by no means changes or puts into code specifications on benefits or contracts. Instead, it prioritizes the patient's interest as that which is protected by the pharmacy benefit managers in the state of Tennessee. It also allows the department an opportunity to use the licensure to ensure quality, as well as to make sure that if a pharmacy benefit manager has an unfortunate record of a lot of complaints, that they can use that to revisit their licensure. And with that, Mr. Chairman, I'll be happy to take questions.
Thank you, Representative Smith. Any questions or comments? Seeing none, are you ready to vote? And all those in favor of sending House Bill 145 as amended to full insurance committee, please signify by saying aye.
Aye.
Any of those opposed, please say no. The ayes have it. House Bill 145 as amended will go to full insurance committee.
Thank you, Mr. Chairman.
Ladies and gentlemen, we are now on item number 6 on our calendar today, and that is House Bill 635 as I turn the page. That is also being presented by Representative Smith. Representative Smith, you are recognized on House Bill 635.
Thank you, Mr. Chairman. And I do have an amendment, but I'll be happy to offer an explanation of the bill briefly before we add the amendment, but at the pleasure of the committee.
Okay. Do we have a motion and an amendment, or excuse me, a motion on House Bill 635?
Motion.
We have a motion and second on House Bill 635. We have before us, we have Amendment Tracking Code 4514.
That's
Once
correct.
again,
Yes, sir.
ladies and gentlemen, we have Amendment Tracking Code 4514. We have a motion and a second on the amendment. Any questions on the amendment? Let's go ahead and put it on. Ladies and gentlemen, all those in favor of placing Amendment Tracking Code 4514 on House Bill 635, please signify by saying aye.
Aye.
Any of those opposed, please say no. The ayes have it. We are now on House Bill 635 as amended. For your explanation, Representative Smith.
Thank you, Mr. Chairman and committee. In the state of Tennessee, we have a definition of medical necessity or medically necessary that's in code. And also in the state of Tennessee, in our practice of medicine definition, as well as in our practice of the healing arts of medicine definition, there's some language that specifically says that there is nothing that will restrict the physician from exercising independent medical judgment in diagnosing and treating patients in Tennessee Code 63-6-204. Also in 6811-205, it says that employing entities shall not restrict or interfere with medically appropriate diagnostic or treatment decisions. And hence we find ourselves in a conflict because the practice in Tennessee and in our code, the term medical necessity and or medically necessary has been put into code in perpendicular position to that definition of the practice of medicine, meaning that if Dr. David Hawk is my physician and you encounter me as a patient believing...
You should be very scared if
I
that
should
happens,
be, and you're not even king for the day either. But, Mr. Chairman, but if you determine I have a diagnosis upon my physical exam and I should receive a certain level of treatment, in practice what happens in the state of Tennessee, your medically necessary judgment is overruled and the burden of proof is put on you as a licensed physician in the state of Tennessee, and you have to overrule, and the burden of proof is on you rather than the other examining entity or the payer. What this bill simply does, it changes those definitions and reverses that burden of proof. This does not prevent prior authorization. This does not prevent utilization review. And even the amendment that we added, colleagues, this pulls out workers' compensation because the Workers' Compensation Administration uses nationally recognized occupational diagnostic guidelines. And so if physicians that are impaneled to oversee patients that are being treated for workforce injuries, as long as they are explicitly using those guidelines, they are out. That is already determined as medically necessary. In this particular bill, it would apply to the application of commercial insurance. And I'll be happy to work with my colleagues at TennCare. This did receive a favorable recommendation for the Council on Pensions and Insurance, but we can make some minor adjustments. But again, back to the premise of this bill, it's to prioritize patients and doctors, making sure that medically necessary is determined by the examining physician who has possession of the medical record and not anyone that would be in a third-party position. And with that, Mr. Chairman, I will gladly take questions.
Thank you very much. And I'll begin the questioning, and forgive me as I was looking at the amendment this morning, and thank you for the work on this. And I should have asked you this previously. I'm wondering about if the Department of Health has an actionable item if there is a concern with a physician that something was improperly ordered and their action has to be taken by someone at the Department of Health. what does this legislation do to the Department of Health should they need to take action against a physician?
Mr. Chairman, I don't have a specific, I can't bring an example to mind. If you could offer a clinical example of the Department of Health having, would this be like in a health department situation, or what kind of clinical environment would we find ourselves?
And forgive me, I've probably overthought this as I'm having this thought. If there's an action or if there's something ordered.
Mr. Chairman, I'm happy to if the department wants to offer an example.
I think I'm looking at Chairman Terry, and he may be able to. Maybe if I'm on base with this commentary. Chairman Terry, you're recognized.
Thank you, Chairman. Are you asking if for something the Board of Medical Examiners had an issue with somebody and not the Department of Health? Is that what you're asking?
That's a more accurate.
Right.
Yes, that is.
Thank you, Mr. Chairman. And as I understand the question that's being asked is if someone were under review or disciplinary observation, there are processes already in place for boards of medical examination and other practice opportunities for people to be put on supervision, for having their license suspended, things like that. So I would not be concerned about the inability to intervene if someone was practicing in a malpractice type situation. But in this case, just like I'll give you an example. In the Council on Pensions and Insurance, our colleague, Mr. McAnally, representing the state plan, testified that the state plan had denied $40 million of care because they deemed it to be outside the bounds of medically necessary. And that, again, that may be appropriate, but in the reality of people who pay their premiums, people who expect to have access to care, sometimes it just prolongs access to a medical treatment. And I dare say that there is someone who sat in my office in recent days who missed 10 days of work because they're having to go an alternative path for care for an injury just to meet the terms of the insurance company as opposed to what their doctor wants. And so we're seeing people that are out of work. We're seeing people that are paying additional health care costs rather than just getting what their physician wants. So in this particular case, what this law would do is just all throughout code reverse the burden of proof for medical necessity to be disproven by the insuring entity or the bureaucracy as opposed to the physician or provider who has spent any number of years studying, being licensed under their Board of Medical Examiners, as well as carrying the medical malpractice policy.
Chairman Terry, you want to be recognized and try to read my mind again, obviously. So,
thank you. And Representative Smith brought up a point about the state denying outside medical necessary, and that brought me to a bill that I happened to run several years ago that did not pass. And my question, you may know this, you may not know this, the denial for medical necessary, the entities that denied this, were the physicians on their staff that denied that, were they licensed in the state of Tennessee?
You recognize Representative Smith?
That's a great question. I don't know that. I know that in certain practices in insurance, they will hire consultants to serve as their utilization review and their peer panel. Sometimes those people are indeed licensed in the state of Tennessee. Sometimes they're not. But that is something that insurance companies employ various professionals, but they don't necessarily have to, by code, be licensed in the state of Tennessee.
Thank you.
Thank you. Chairman Kumar, you are recognized.
Thank you, Mr. Chairman. Thank you, Chair Lady Smith. Several things come to mind. One, are we saying the physician, clinical person examining the patient will be the sole arbiter of medical necessity?
Thank you. Not at all. This does not change the role of utilization review. This does not change the role of prior authorization. This, however, puts the burden of proof on the entity that's going to challenge that practitioner.
Okay. Thank you. So if a physician recommends an MRI, the guidelines that the insurance company has say the patient is not ready for that, they should have so many weeks of physical therapy and so on, then how will the determination be made in that scenario? Would the guidelines trump the physician judgment, or would the physician determination that this is medically necessary trump the guidelines?
Chairlady Smith.
Thank you, Mr. Chairman. And Chairman Kumar, based on diagnostic and in the case that you're talking about, someone needing an MRI, if someone has a back injury, there are different levels of pain. There's different types of recording in the patient medical record, as you're aware, that will change the level of acuity and move that patient to a more critical stage than someone that has just a mild strain, as opposed to radiculopathy, loss of function, the inability to return to work, those type of things. And what I would just challenge the thought process is, this is not rhetorical. Are we going to honor our Tennessee Code annotated and allow physicians to practice medicine? And are we going to have medical necessity listed in code that will parallel that and support that and allow the burden of proof that they're witnessing, they're seeing the patient? A peer review person never touches the patient. They never have the patient squeeze their hand and experience grip loss and change of muscle tone, et cetera. And again, not to burden the insurance, we need insurance. I would just simply say in the state of Tennessee, it has been my passion that we protect the physician-provider relationship with patients as opposed to treating access to a health insurance policy to mean that you have health care.
Chairman Kumar.
Thank you. I mean, as clinicians, we have all struggled with the situation where we know this patient needs this, and, quote, the insurance company didn't approve it. We've all struggled with that, and we have been advocates for those patients, calling and having peer-to-peer conferences with the review person at the insurance company, and generally they've been very helpful. But still, we've all struggled with that. I'm not getting able to determine if there is a conflict between guidelines and the physician judgment. Who will make the decision? Will it just come back to what it is now, that is a peer-to-peer conference with the medical officer at the insurance company, which is a reasonable system depending on availability?
I would just simply, thank you, Mr. Chairman. I would just simply respond that, physicians and providers are very reasonable. If guidelines are clear and they support a patient presentation, then I think that the practitioner would comply. I don't think that most physicians in the state of Tennessee and or providers would be unreasonable to press the issue. Again, this is just going back to what we're seeing. More and more cost savings are done by denying care to people that have paid their premiums, and it is empowering individuals that never touch clinically the patient.
Thank you, Chair Lady. I admire you for carrying the burden and the load, the flag for our patients. Thank you.
Thank you. Chair Lady Rudder, you're recognized.
I want to thank you, as we've talked to my office recently, for carrying this bill. This is very personal to me because I know the heartache and the time that patients sometimes suffer because of someone else getting between the doctor and the patient. My daughter falls in that category. She's a very smart person. She advocates for herself a lot of times. As we've talked, there's sometimes people are not able to do that, and they're not able to be able to argue with insurance companies and advocate for themselves. My daughter does not live in the state of Tennessee, but I support this bill. I think it's very important for the doctor and the patient to have that relationship. And I do understand about cost savings. Would be an advocate for that, but I think there comes a time when the doctor has to be, his opinion has to be respected. And people that are sick, just we should recognize and honor that, as well as we honor and recognize cost savings. There's a time when we have to say the doctor knows best. And these patients should not have to sit on the phone for hours and advocate for themselves through insurance companies to try to get an MRI or whatever it may be. So very personal a situation to me. I support your bill. Thank you for bringing it.
Thank you, Chair Lady Rudder. We do have some folks on the list who would like to testify or would like to speak about the legislation. We have Tennessee Department of Commerce and Insurance, both Alex Lewis and Patrick Merkel, if one of you gentlemen would like to speak. In addition, we have individuals from TennCare who have requested to speak on this legislation. I'll let you all decide who would like to go first. All right, we will go into recess for the moment with the purpose of hearing testimony. We will begin with folks from Tennessee Department of Commerce and Insurance. Mr. Lewis, if you could please introduce yourself, tell us who you are and who you're with, and begin your conversation.
Thank you, Chairman. I'm Alex Lewis with Tennessee Department of Commerce and Insurance. Our position and the position of several other departments who may want to speak with more specificity, Health, Finance and Administration, and TennCare, about the impact to their departments. From our department, we see this as an undermining of the way that insurance and healthcare works right now that could likely lead to increased costs to consumers. We're concerned that it would undermine the ability of insurance companies on behalf of consumers and plan sponsors to be able to use cost-saving measures in order to ensure that the plan itself is in good shape. So from the department standpoint, that's where we stand.
Thank you. Any questions or comments? Chairman Subcommittee, you're recognized.
Thank you very much. You painted in very broad strokes there. I need you to be more specific because we have to vote on a bill here.
Sure, and I acknowledge that I wasn't planning to testify on this one, so some of my colleagues were. The fact that, as the sponsor said, this shifts the burden from the insurance company or from the provider to the insurance company. We know that insurance companies use utilization review, pre-certification, pre-authorization in order to ensure that best practices are followed. And while we do trust our providers, we do know that there is lots of academic research going on all the time about the efficacy and the efficiency of courses of treatment. And the benefit of the utilization review, pre-certification, pre-authorization, all of those things is that a practitioner who is busy serving patients, whether that be in an urban clinic or a rural clinic or anywhere in the state, doesn't always have the time to keep up on all of those developments. And while they are licensed and practiced and we trust them, there are developments that can lead to better outcomes for patients. And those, we feel, could be undermined by the bill.
Chairman Subcommittee.
So there's constant innovation going on right now in the medical field. Is that correct?
Yes, sir. I think some of the members of the committee who are in the healthcare field would attest to that.
And so most of those medical discoveries either come in a laboratory or they come clinically through trial, correct?
As a non-clinician, I can't speak to that, but that would make sense.
Neither am I, so we're just having a conversation.
Yeah, that would make sense to me.
Okay. So wouldn't it behoove us to make sure we give maximum flexibility to our providers to make sure that they have the flexibility to provide what's best for the patient, that they know instead of a bureaucracy at the highest level? Would you want your doctor prescribing what's best for you or what someone in office says?
I would like for my physician to have the access to the greatest amount of information possible. And pre-certifications, pre-authorizations add that extra layer of information that would be beneficial to me as a consumer, I would think. And I know that, as the chair lady said, these are very personal situations. And the department, that's not lost on the department, but we think that this is a valuable tool.
Chairman Sapicki.
And I'll keep asking, Mr. Chairman, until you just tell me to keep going back and forth here. Is it better for our doctors, nurse practitioners, fill in the blank, who know their patients? Is it better for them to have the ability to prescribe or diagnose what's standing in front of them as the proper care for that individual? I don't want my doctor prescribing to me based off of what's in a catalog. I want my doctor prescribing what's best for me standing in front of him, because you're different than I am. Everybody here is different from each other, and a doctor should have that flexibility. Now, I understand there are still checks and balances in the system that make sure that there's no abuse, that doctors still have to answer to. I think it's called a review board if they get out of hand, because we see that periodically, that pops up. I'm struggling here of trying to find out why commerce, right, is standing in front of us saying they don't like this bill, which I think, from being a non-clinician, is trying to provide better health care to our individuals.
I'll try and walk my way back through that. Yes, there is certainly an advantage to a physician having flexibility. And while you may want your physician to be able to make your provider, healthcare provider, to make any diagnosis or course of treatment available to you, that isn't necessarily what the healthcare industry has seen as the best for outcomes from a healthcare economy standpoint. And so the tools that we feel this bill would undermine are used to ensure that those are in place. And so as the Department of Commerce and Insurance, we feel that it's important for us to look out for and protect consumers. And we feel like undermining those protections that are built into the system as we have them could have detrimental effects both to the health of consumers. I have a report that I recently read about, an academic report that talked about inappropriate prescriptions and inappropriate tests, and how some of those can lead to actual harm instead of just a benefit. And that's not to say that that happens all the time. But this bill, we feel like, would undermine some of those protections that would inevitably also lead to higher costs to consumers.
Last one, I promise.
Chairman Sapicki.
We keep circling back to money, which drives me crazy in healthcare. It always keeps circling back to money. I know I'm not on the education committee here, but I keep hearing money up here all the time. We should be doing what's best for the patient, period. Okay? Now, I understand there's insurance companies. I understand there's other people involved here. I understand that the medical profession, I get it, right? Does this bill eliminate, I think it's called review of a doctor? Does it eliminate that?
Does it eliminate the review of the licenses of physicians?
No, is what Chairman Terry said, medical review.
And I think that's what I was getting to earlier with the potential concern, and forgive me for interjecting there.
Does this bill eliminate medical review of our doctors?
From a licensing standpoint, it does. I would defer to the Department of Health to answer that question. They license physicians.
Are they here?
Let's move on, Chairman Spicky, and we'll see if we can find somebody there in a few minutes. Chairman Terry, you're recognized.
Thank you, Chairman, and I appreciate you coming to testify. And this bill has me thinking, and it actually has me going back to when I was an intern. And it's a case that I remember. I'm not going to give anything away from a HIPAA standpoint, but it's imprinted in my mind. And it was a patient that came in, and my attending had to have a conversation with somebody, and he said this patient needed X and said it was medically necessary, and he was denied and said you have to do something else. And my attending explained that to the patient, and even though the physician, my attending, said it was medically necessary, the patient took it upon themselves that they were going to take that route. And this, even though the person they were talking to on the phone never saw the patient at all, ends up, while the patient was waiting to have another procedure done that the physician said he didn't need and was going to fail anyway, there was a bad outcome for that patient. So, to me, I'm of the opinion, EMTALA, Emergency Medical Treatment Active Labor Act, if it's an emergency and it's medically necessary, it needs to be covered. And, this bill, I'm supportive of the concept of this bill. I'm on the bill. I think we're onto something here. But that's an issue that I've had that I would like to share, that whether it helps or not, I do think we need to address this issue. So thank you.
Thank you, Chairman Terry. Dr. Kumar.
Thank you. Thank you, Mr. Chairman, and thank you, Mr. Lewis, for your explanation of things. While I'm at it, thank you, Chairman Smith, for bringing this up. It makes us think back to the situations we have come across where we struggled with getting approval for a patient who much needed it. And also, just a few months ago, I was tired of getting injections in my shoulders, and it was not getting better, and I thought I needed an MRI. Our insurance turned it down and said you need a few weeks more, and guess what? My shoulder was better a few weeks later. So life is a balance, and I think we're trying to balance his patient welfare with the overutilization of facilities and costs. And I sincerely, after a lifetime in medicine, I don't have an answer for it, but I think if people would just be reasonable and take care of patients who need to be taken care of and yet not overutilize, we will be fine, and I wish us all the best. Thank you.
Thank you, Dr. Kumar. Any other questions or comments for Department of Commerce and Insurance? Thank you, Mr. Lewis. Department of TennCare. Anyone, Ms. Reed, and anyone you'd like to, once we sanitize and take our proper protocols here.
To figure out what you mean. But there are situations we have doctors, like the situation with insurance companies, right?
All right, I see, Ms. Reed, we have you with there, and we have Mr. William Aaron as well. When you prepare and get ready to speak, if you could please introduce yourself, let us know who you are and who you're with. Who would like to be recognized first?
Ashley Reed, Division of TennCare. I do have a couple of other folks with me here to answer questions if needed. TennCare is opposed to House Bill 635, which seeks to set in statute a definition of medical necessity that would fundamentally change the way the TennCare program operates today, open the door to care that is clinically inappropriate for our members, and eliminate TennCare's ability to effectively manage the growth of healthcare costs. Our current definition of medical necessity has been in place for more than 15 years and was a fundamental piece of the TennCare reforms put in place in 2004, when the executive and legislative branches worked together to address a runaway Medicaid program that was literally going to take almost every available new state dollar by the year 2008. In fact, this subject was so important that the legislature specifically put the current definition in statute, and it has served the program extremely well. The proposed definition in this legislation is substantially different from the definition in place today. Most notably, the definition in this bill shifts the burden of proving medical necessity from a clear standard based on medical evidence to solely on TennCare. This would make it impossible for TennCare to ensure appropriate care and manage costs as we have under our current definition. Our definition of medical necessity is a fundamental principle of our program and impacts all areas of spend. If required to use the definition of medical necessity set forth in this bill, we would be unable to assure members receive appropriate care and would see significant increases in our cost trend. Under our current definition of medical necessity, we have demonstrated for more than a decade national leadership in providing world-class health care at a sustainable cost for the people of Tennessee. For context, we have not been able to find a medical necessity definition in Medicare, commercial insurance, or 42 other Medicaid states that have their definition of medical necessity publicly available that is identical to this definition or one that places the burden of proof on the insurance entity. This definition is contrasted with our current 5-pronged definition of medical necessity based on orders from a treating provider, treating a medical condition, safe and effective, not experimental or investigational, and the least costly alternative, where each of these terms are clearly defined in our rules. The change proposed in this legislation to make the presumption of medical necessity if the treating provider documents it is in the patient's best interest would functionally eliminate our ability to perform utilization management and our standing in medical appeals, further weakening our ability to control costs. It is also really important to note that at its core, the definition of medical necessity currently in statute is about much more than controlling costs. It is also about ensuring the right care that is clinically appropriate as determined by the medical community using the most current medical guidelines and criteria. Examples of inappropriate care that may be prescribed in the absence of our current medical necessity definition include treatments that were once commonly accepted before new clinical guidelines changed. These include, but are not limited to, the overuse of antibiotics for sinusitis, which is not only fiscally irresponsible, but could also lead to antibiotic resistance and be harmful to the patient. An additional example would be the ordering of annual electrocardiograms or any other cardiac screening for low-risk patients without symptoms. There is little evidence that detection of coronary artery stenosis in asymptomatic patients at low risk for coronary heart disease improves health outcomes. False positive tests are likely to lead to harm through unnecessary invasive procedures, overtreatment and misdiagnosis. Potential harms of this routine annual screening exceed the potential benefit. Both of these examples came from recommendations of the American Academy of Family Physicians. This legislation also has significant implications for the TennCare 3 or shared savings waiver. As you may have heard Director Smith say, for us to succeed and earn shared savings for the state, all that we need to do is continue to do the same things we have been doing in recent years. The things that have gotten us to a point where we consistently manage costs below the average or projected growth trend for Medicaid programs. There is no question this bill changes our ability to maintain that success. In other words, we would effectively be spending any shared savings we might achieve on the front end without adding any new services, benefits, or members served. To conclude, this bill is also inconsistent with federal regulations requiring that states establish methods and procedures to prevent the unnecessary utilization of services, and it has implications regarding the federal definition of medical necessity.
Thank you, Ms. Reed. You were going over 3 minutes, as you said in conclusion, so I'll let you continue with your conclusion. So just for the record there. I will say that this does bring a conundrum before this committee and personally before me, because I spoke on behalf of the TennCare Shared Savings Plan a few weeks ago in session and mentioned the efficiencies that we have seen over the last 16 years. And so it does certainly present a concern and a financial concern. As we're still in recess, questions and comments for TennCare? Chair Lady Smith, you're recognized.
I know that there are two different MCOs, and that may change. There may be more MCOs that are contracted under TennCare 1, 2, 3, whichever iteration we're under, which we need. Does each of these MCOs operate on the same identical set of guidelines? And is it standardized across the board as far as enforcement, utilization review, et cetera? Thank you, Mr. Chairman.
Yes, we currently have 3 MCOs. This definition is standardized. It is set in rule and in statute. All 3 of our MCOs utilize this same rule, which has really provided a lot of consistency for providers, as they know exactly what's in the medical necessity definition, and we think has served well, this definition being in statute and all 3 MCOs using it.
Questions or comments for TennCare? Seeing none, thank you very much. One more name on the list to speak. One last name on the list, Scott McAnally. We'll get ourselves all cleaned up here. And this is the last that has requested testimony on this particular piece of legislation. Mr. McAnally, if you could please introduce yourself, tell us who you are and who you're with.
Thank you, Chairman. Scott McAnally, Division of Benefits Administration with Department of Finance and Administration. We also oppose the bill. We read it as replacing the existing statutory definition for medical necessity. We're in a little bit different spot as TennCare because we don't maintain our own in-house definition. We defer this largely to the carriers, except for instances where services are specifically excluded in our plan documents, and it's unclear whether that would apply here anyway. The definition of medical necessity that we've been given by our providers does mirror what's currently in statute. That would require medically necessary services to have written criteria, to be clinically appropriate, to not be primarily for the convenience of the patient or the provider, and to not have a therapeutic or diagnostic equivalent with a cheaper cost. So this would change all those requirements as we read it to be, well, as the bill is introduced, to be in the patient's best interest as determined by an unknown party, and then probably clarified in the amendment as the patient's best interest as determined by the treating provider. So we don't read that as completely doing away with the utilization review. We do read it as changing the standard. And as Chairman Smith had mentioned, I think we had saved $40 million in avoided costs in 2020 through medical necessity reviews. So we consulted with our actuary as to how many of those savings we would likely retain if the bill were to pass, and their opinion is that we'd lose about half. So that is it's actually over half on the amendment, so I think it was $26 to $28 million, and that would be about $12 million in states impact. The remainder comes from patients, comes from our members, and comes from the local governments that are on our plans.
Thank you. Chairman Terry, you're recognized.
Thank you, Chairman. Thank you for being here. Just a quick question on the utilization review, and this goes back to the issue and experience that I had in my training previously. But in the case of emergency, shouldn't we put the patient first as opposed to doing utilization review and then letting the patient wait for that?
Thank you, Chairman. I'm not sure how the bill applies in urgent care situations. Of course, the definition of medical necessity will change for all services. I believe there are already provisions in statute for an expedited review under any kind of emergency situation.
Chairman Kumar, you're recognized.
Thank you, Mr. Chairman. I'm not an expert and don't take it as the final word, but my impression clinically was that in an emergency, pre-authorization and so on does not really matter. You go on because emergencies happen after the insurance company offices are closed. And as well as weekends, when somebody sees somebody in the emergency room and they need to be admitted, we would go ahead and admit them, and then utilization review people would look at it on Monday, and by that time we've taken care of essential things. My question to you is, when you say that you were able to save so much money in certain situations using the proper guidelines that you have and not allowing either a procedure or a test and so on, you were able to save that money. is there a mechanism that when we deny care to the person that was recommended by the physician, and the insurance company denied it, that care did not get provided 6 weeks later, 8 weeks later, somebody follow-ups and looks at it, what was the outcome, in the sense that the deniers, do they look at it and say, we were right or we were wrong, we need to learn from it? Is there a process along those lines?
Thank you, Chairman. I think since we don't currently provide that function, I don't know that we would go back and review how adverse determinations have played out amongst our membership. I think it's a worthy question. I would hope that, to go back to current questions we've heard, if someone's being interjected between a patient and provider, I think it makes perfect sense to make sure that there's scrutiny on those decisions that are being made. Of course, this is a question of payment, right? So if you can pay the cost, if you're in a direct primary care situation, I don't believe any insurer would tell you, that you can't have a service. If you are asking, in our case, the state to fund a service on behalf of state employees, I think that's why we think that, the existing criteria for medical necessity are appropriate.
Chairman Kumar.
I would consider that to be an internal quality review, so to speak. Are we denying it in the right situations and so on? Maybe that's the subject of another legislation. Thank you. Thank you, Mr. Chairman.
Thank you. Further questions, comments? Committee, I ask your, Mr. McAnally, thank you very much. Committee, I ask your forgiveness. I had looked at my list, and Mr. McAnally was on a different bill. I called him up, so Mr. McAnally, you got a freebie. You got a freebie on me, and that is my mistake, and I apologize. Ladies and gentlemen, thank you. Ladies and gentlemen, we will go back into session. As we look at the clock, I know that Chairman Subcommittee, you're recognized. Question has been called on this piece of legislation. Any closing comments, Chair Lady Smith?
I appreciate your indulgence. I just wanted to close with this comment. The definition of insurance. Insurance is a contract represented by a policy in which an individual or entity receives financial protection or reimbursement against losses from an insurance company. The company pools clients' risk to make payments more affordable for the insured. Insurance policies are used to hedge against risk of financial loss, both large and small, that may result from damage to the insured, his or her property, or from liability caused to a third party. We did not hear the practice of medicine. We did not hear anything in that about the patient's best interest. And what I would just submit that the deliberative work of this body is to prioritize patients, and I'm happy to work with stakeholders as we move this bill forward, but I would ask the committee to vote in the affirmative today to put patients first. Thank you, Mr. Chairman.
Thank you. Parliamentary procedure, the question has been called. The sponsor of the legislation has delivered final comments. We will now vote on House Bill 635 as amended. All those in favor of House Bill 635 as amended to send the bill to full insurance, please signify by saying aye. Aye. Any opposed, please say no. No. The ayes have it. The bill moves forward. Ladies and gentlemen, we are up against the clock. Chairman Subcommittee has the next committee in this room. We have item number 7 on our calendar with no objection. We have run out of time. That bill will go to the next calendar, as well as the item that was rolled to the heel of the calendar. Those bills will go to next week's calendar because of time concerns. Seeing no objection to an adjournment, we are adjourned.